up everybody? Welcome back to my YouTube channel. I am Dr. Allie. I'm an OBGYN, and here on YouTube I like to talk about all things women's health, from pregnancy, periods, anything and everything in between we cover on my channel. If you are new to my channel, welcome. I am so happy you are here. I really hope that you guys learn from these videos, that you love this content. I would love it if you hit that subscribe button, give me a thumbs up, let me know that you guys are liking these videos. Okay, so a little intro into today's topic. I posted on Instagram a little poll asking you guys what you wanted my next YouTube video to be, and here are the results. Overwhelmingly, you guys wanted me to talk about the labor process. So here we are. Now, if you guys don't follow me on my social media platforms, I will leave linked below my Instagram, my TikTok account, which I love TikTok. It's just, if you don't have TikTok, what are you doing? It's so entertaining, so many good content creators, so many funny videos. I love TikTok. Now in today's video, I'm gonna talk about labor and the laboring process. I'm going to focus on for women who go into labor spontaneously on their own. Now this could look significantly different if you have to be induced. So that could be a topic for another video. All right, without further ado, let's get started. Now I want to start off by saying that this labor process can look slightly different depending on what country, city, or hospital you're in. Every single hospital is going to have a different policy, and as we all know, COVID changed so much. So if you're curious about what this process is going to look like for your own hospital, I would recommend reaching out to your hospital or even asking your doctor or healthcare provider so that you can be properly prepared on what to expect in the facility that you're going to be in. Now, to make this video a little bit easier to follow, I've broken it down into 5 different areas. 1 being the start of labor, 2, triage, 3, admission, 4, your labor course, and 5, delivery. You guys, I gotta do a quick shout out to my nails. How cute are these? If you're not into the mixed matched nails, I know you won't like them, but I tried these out on my Instagram stories the other night and I'm obsessed. I'll leave them linked down below. It's Vanity Official, I think is the name for it, but obsessed. All right, so let's start talking about it. Number 1, going into labor. So let's say now you are full term, and if you remember from my video all about the 3rd trimester, this means anything from 37 weeks and beyond. I will leave links to that video down below so that you guys can check it out. I actually have a whole series where I talk about 1st trimester, 2nd trimester, 3rd trimester, now labor, and I will eventually do a video on the postpartum period. Okay, so you're full term, you're hanging out at home, and all of a sudden you start to feel contractions. Now it's important for you to track your contractions. I would start by writing down how frequently you're feeling these contractions and how long the contractions are lasting. You can do this the good old-fashioned way by just using a clock, but I know there's a ton of apps right now that you can download to help you with tracking contractions. Also pay attention to how you're responding to the contractions. Are they pretty mild? Are you still able to move, walk around, live life normally? Or are these contractions stopping you in your tracks, requiring to kind of focus in because they're hurting so much? Or are you really having to like breathe through them? You're huffing and puffing, and they're very painful. Depending on whether this is your 1st baby or your 5th baby, this may look very different for every person. But typically the recommendation is if you're having regular, painful, you're very uncomfortable type of contractions, we'd want you to go into the hospital for evaluation. Now, another thing that might happen is your water breaking. And for this little segment, I'm gonna become a Mythbusters here. It has been historically known that if your water breaks and you don't feel contractions, you shouldn't go into the hospital. You should just sit at home and wait for contractions to start. Absolutely not. This is a myth. If your water breaks, you should go to the hospital. So if your water breaks, regardless of whether or not you start to feel contractions, it's important for you to go to the hospital, and let me explain why. The longer that your water is ruptured, the higher chance that you may develop an infection. So we want you to go to the hospital so that we can evaluate your labor and make a good assessment of what's going on. Reason number 2 would be to avoid things such as a cord prolapse. A cord prolapse is when your water breaks, and if your cervix is a little bit dilated, the umbilical cord can actually slide through the cervix, and that umbilical cord will just sit inside of the vagina. It can become compressed. If that umbilical cord becomes compressed because it's either stuck in the cervix or within the vaginal tissue, obviously any point that the umbilical cord is compressed, that is decreased blood flow to baby. A cord prolapse is a medical emergency that requires a C-section to get baby out safely. The longer that umbilical cord is compressed, that's less blood flow to your baby. Okay, so let's move on to the second part, triage. So you start feeling these contractions, your water breaks, you come to the hospital. The first thing you're going to do is go to OB triage. So the first stop is going to be for you to do your registration. They're going to ask you your name, date of birth, blah, 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 all that stuff. As soon as you're done with that, they will move you to triage and place you in a room. In triage, you're going to have a nurse that's going to take your history, ask you about when your symptoms started as far as contractions, when you think your water broke, how are you feeling, what do you rate your contractions on a scale of 1 to 10, etc., etc. While she's doing this, she's also going to put you in a hospital gown, and she's going to put you on the fetal monitors. Now, the fetal monitors are going to trace your baby's heart rate and also track your contractions. With fetal heart rate monitors, we get so much information about the health of your baby and how your baby is reacting to labor and contractions. So as soon as your nurse is doing all of her evaluation, she's then going to do a physical exam and she will check your cervix. Then at that point, we'll know how far dilated you are. After that, the nurse typically will call the doctor, whether that's your own personal doctor or the doctor that's on call. That's just gonna depend, again, hospital to hospital, practice to practice. So ask your provider exactly what the setup is at your place, at your hospital. So the nurse calls the doctor. During this phone call, a nurse calls me and tells me, hey, we have so-and-so patient, she's this years old, she's this far along, this is her first baby, and this is her cervix. From there, the doctor can give orders to the nurse, whether that be directly admit to labor and delivery, giving some sort of medication if that's necessary, drawing blood work if that's necessary, having the patient kind of walk around, rechecking her in an hour, stuff like that. Now, the decisions that we make as OBGYNs as to whether or not we directly admit someone or send them home or have them walk around is going to vary person to person. For example, if someone is a multip, meaning this is her 5th pregnancy, she's 6 centimeters dilated and in a lot of pain, that patient is going to get directly admitted to labor and delivery. Now, if this patient is a primip, meaning prima gravid, which means she's never had a baby, she's 1 centimeter dilated, her cervix is still really long, thick, it's really posterior, in that case, these aren't signs of active labor and we may send that patient home. There's always the option of having the patient walk around and then rechecking her cervix in an hour to see if she's made any cervical change. If her cervix goes from 1 to 3 centimeters, 4 centimeters in a span of an hour, then this is truly active labor. If after you recheck them in an hour, the patient is now more comfortable, no cervical change has been made, then we may send you home. It's hard for me to predict, obviously, what's going to happen because this varies, again, patient to patient. So another example of what can happen, say you do come in, you're only 1 centimeter, you're really not contracting that effectively to make cervical change, but something else comes up. Your blood pressure is elevated, your baby on the fetal monitoring doesn't look all that great, heart rate starting to dip, anything like that, then those would be indications to keep you and probably induce your labor. But for the sake of this video, let's say you're in active labor and the doctor admits you to the hospital. Yay! That means you've made it now to phase 3. So phase 3, admission. So yay, you've made it to this part, you're getting admitted to labor and delivery, and it is baby time. Well, maybe not baby time right now. You have to make it to 10 centimeters, but you know what I mean. It's getting real. You're gonna have a baby. Now that you're admitted, you're gonna be moved to a labor and delivery room. Nurses are gonna continue to take your full medical history. You'll get past medical history, past surgeries, allergies, medications that you're currently taking. You're gonna be asked these questions likely several times, and that's okay. We just wanna make sure that everyone that's going to be involved in the birth and delivery process is on the same page. So typically during this time is then when your doctor or the on-call doctor will come say hi to you, welcome you. Obviously, if it's a patient that I know, then it's just, getting excited, getting ready for this labor process. During this time, I like to go over expectations on the labor process, delivery, all of the good stuff. Obviously, we go over any risks and benefits, any additional lab work that we may need to order, if my patient can eat, if she can walk around, etc., etc. This is all going to depend on the patient, if she has any comorbidities. So it's gonna look different for everybody. All right, now that you're all checked in and you're admitted to labor and delivery, you're also going to be assigned a labor and delivery nurse. Now, these L&D nurses, I gotta tell you, they're amazing. They're going to be your best friend and your advocate during this whole process. They're gonna be at your bedside more than I am as a physician. Typically on most labor and delivery floors, they assign one nurse to one patient, sometimes one nurse to two patients, but obviously the process of laboring can get very complicated very quickly, so they try and limit the amount of nurse to patient ratio. Again, your nurse is there for you. Any questions, doubts, anything that you need, definitely your #1 point of contact. Okay, you've made it through the whole admit process. Now let's talk about number 4, the labor process. Depending on the plan that you came together with your doctor and your nurses, labor can be anywhere from a couple minutes to hours to even days. Again, this just varies patient to patient. If there's an indication for delivery, or again, if it's your 5th baby, things tend to move a little bit faster. Patients ask me all the time, when is my baby going to be born? If you're admitted in the morning, are you gonna have your baby in the afternoon, at night, the next day? And honestly, I wish I knew. There's no way to tell when your baby's going to be born. I can make a guesstimate, we can take bets on timing of baby, but your guess is as good as mine. Although sometimes it is fun to kind of see what everyone thinks. Like I'll give my input where I'm like, oh, I think it'll be 3:15. And then the partner's like, no, it's gonna be 4. And the mom says this like obscure number. And I don't know, I think it's kind of fun. But at the end of the day, it is nothing that you can control or I can control. Baby is going to come when baby decides to come. So the biggest thing to remember here is that patience is key. This is a marathon, not a sprint. Now let's talk about epidurals. With my experience working at bigger hospitals, there's always anesthesia on staff or in-house 24/7. That means that when one of my patients requests an epidural, there's someone in-house that can place them. So when you reach the point that you do want an epidural, keep in mind that we do need some blood work back before we can safely place an epidural. Or I should rather say before an anesthesiologist or a CRNA can safely place an epidural. Another thing that's required is that you have enough hydration and fluids in your system before getting an epidural. This process might take anywhere from 20 to 30 minutes. If you're feeling like your contractions are getting stronger and you're getting more and more uncomfortable, it may be something to mention to your nurse. Now, quick little side comment on epidurals. I do not care if you get an epidural or if you want to go unmedicated. I want you to do what's best for you. And no one should ever shame you for wanting an epidural. I see this all the time where family members tend to shame on a woman that wants an epidural. We need to completely stop this narrative. It doesn't matter. This is your birth. You're the one that's going through this process, so you get to decide what you want. So a lot of women also ask me too how often they're going to have a cervical exam during labor, etc., etc. There is no cold, hard rule on how many times we need to check your cervix when you're in labor. And honestly, we probably don't need to be checking like every single hour or every 2 hours. If you start to feel more uncomfortable, you feel more pressure, you feel like you have to have a bowel movement, that might be a good idea to check your cervix and see how far dilated you are. It's also necessary to sometimes check your cervix a couple times throughout the course because we want to see what you're doing. We don't want you to just sit in the hospital bed and stay dilated to 4 centimeters and not make any change. In that case, if a woman isn't changing her cervix appropriately, then it might be a good idea to augment your labor. The labor augmentation, that means giving you medication like IV Pitocin to make your contractions stronger so that you do make that cervical change. So throughout this entire time, your nurse is in direct contact with us as providers. They're giving us updates, keeping us informed on what baby's looking like, what your cervix is dilated to, and all that good stuff. We're also available in case we need to be at the bedside for an emergency, or if they have some sort of doubt and we need to check your cervix, if we need to break your water. So the nurses are able to communicate to us anything that's going on and keep us updated throughout your labor course. Once you are 10 centimeters, you have made it to complete dilation and it is now safe to start pushing. So that brings us to part number 5, delivery. So you've made it to complete dilation, that magical 10 centimeters, and it is baby time. Typically, once you're 10 centimeters, the nurse calls us and gives us an update saying that you're completely dilated. Most hospitals, the nurses will do practice pushes with you, which means you'll just do a couple pushes to see how you're doing. They'll coach you through how to effectively push, etc., etc. But again, this could look different hospital to hospital. Where I did my residency training, the residents actually did a lot of the coaching and a lot of the practice pushing once the woman made it to 10 centimeters. Once you are effectively pushing and baby is moving down your pelvis, that's when we will get a phone call that we are ready for delivery. So once we're ready to have a baby, we make sure that everything is set up, that I have all of the tools or equipment that I may need, that nurses are ready, that if necessary, we have a pediatrician or a pediatric nurse in the room in case we're expecting some sort of complication with baby. Now, I know you've all heard of the typical ways to push where you take a big deep breath like you're going underwater, hold all that air in, and then just bear down. Typically, we count to those 10 seconds, have you take a big deep breath again, and push for another 10 seconds. Now, maybe that type of pushing isn't always effective for everyone. So if a woman feels more comfortable pushing another way, that's fine with me. Now, keep in mind that epidural or not, labor is a lot of work and it is very exhausting. Just like I mentioned earlier, this truly is just like a marathon. You're at the home stretch the last little bit, so it's important that you stay focused and stay in control. Once you get to the point that you're crowning, the head delivers, shoulders deliver, and baby is out, as long as baby is vigorous and looks really well, baby goes immediately up on your chest so that you can start that beautiful bonding process. Now, the American College of OBGYNs, or ACOG, does recommend delayed cord clamping from 30 to 60 seconds as long as the baby is vigorous. So that has turned into pretty much the standard of care across most hospitals in the United States. And we all tend to practice delayed cord clamping. Like I said, the recommendation is from 30 to 60 seconds. After that time is up, that's when we can safely clamp the cord, and the umbilical cord can be cut either by you, the patient, by the father of the baby or partner, or by anyone else in the room that you feel comfortable with. So now the cord is cut and now begins that golden hour. So the research has shown that there are many benefits to you bonding with that baby in that first hour, also called the golden hour, that you do immediate skin to skin while holding your baby. Now, some moms prefer the baby to be weighed at that time and then brought back on the chest. It really depends. And you do, again, whatever you feel comfortable with. So me as an OBGYN, during this time, baby's up on your chest, you guys are so in love and enjoying every aspect. Meanwhile, I am waiting for the placenta to deliver. Once the placenta delivers, I'm doing a full evaluation of the vagina, labia, cervix, perineum to make sure there's no tears that need stitches or attention. If you guys are more interested in hearing about vaginal tears during birth and how to prevent them, I have an entire YouTube video on this and I'll leave it linked down below. During this time, I'm also evaluating your bleeding. It is normal to lose blood after every delivery. We expect it. Now, we obviously don't want you to lose too much blood because we don't want this to turn into a postpartum hemorrhage. So we do a full evaluation and make sure there's not any interventions that we need to do. If you have more questions about postpartum hemorrhage, I do have an entire blog post written about this and I'll leave that link down below. Remember that my blog post is written in both Spanish and English. If you do have a tear, we can repair it at that time. And once we're done with that, we get you all cleaned up, and now you just get to enjoy this new little person. All right, so I think that brings us to the end. I hope you guys enjoyed this video and the format in which I kind of, you know, put it in these 5 phases. Let me know what you thought. Leave me any questions or suggestions in the comments down below. I just want to thank you guys so much for all the love and support, for following me here on YouTube or on TikTok or on my Instagram. You guys mean the world to me. As always, I hope you learned something new and that this video empowered you if you're kind of nearing the end of your pregnancy and you're scared of the labor process. I hope this made it a little bit easier to understand and that it prepares you for this new process. All right, you guys, I would love it if you would hit that subscribe button and become part of this little family, or give me a thumbs up if you enjoyed today's video. As always, be kind and show love to everyone around you. I love you guys so much. Have a good day. Bye. Good morning.
Throw mine away. How's the coffee?